Okay, we're doing how to do the lower back flow. When someone comes in with lower back pain, there's a whole bunch of different theories regarding the lower back, whether the Maitland approach or McKenzie or NIAMS or IPA. So this approach is a more integrated approach. We're looking for three things. What's going on, what's the pathoanatomical diagnosis, what's the pathomechanical diagnosis, and what's the driver. Pathoanatomical diagnosis is what is the damaged tissue. Pathomechanical, what is the movement dysfunction. Essentially, are you moving too much or too little? And the driver is what's causing the whole entire thing. So during the examination, we look for those different things. So the main thing we'll concentrate on is what to do in standing. So you pick a motion to test, whether it's flexion or extension or side bending. Sometimes we pick squatting or a step test, depending what is person's primary cause of the pain. So if the pain is mostly with sitting, probably have them do a bending forward test. If the pain is with walking, I could have them do a step functional test. I could have them bend backwards. I could have them move sideways. If they're pain with, if we're picking with children, obviously we'll do a forward flexion test. So it depends what is the functional test that's causing them all this pain. So which joint we'll pretend he has pain with bending forward type of activities. So I have him bend forward. And the first thing I had to do, he's standing right there. Okay, he's zooming in right there. Okay. Just do a quick observation. It's good to start off the side to see if the normal curves are there. Is there a natural number of lordosis? And do you see a rotation? Alright. Then you see when pelvis seems to be higher or not. You're looking for a scoliosis. The next thing is we're going to check out good old-fashioned palpation. The palpation helps us tell us what's the pathoanatomical diagnosis. So we're just feeling what's tender. You tell the person, hey, what's tender? And you go between the spine spaces. If it's tender, it can either be the spine's process, weight bearing too much, or maybe the ligament in the spinous one is being overstretched. Alright, and then you go all the way down to the SI joints. You go medial to that and inferior to that. You want to see if those are tender. Those tell you if the SI ligaments are in dysfunction now, without which indicates a sprain. So something as simple as filling between the spinous spaces, and it has pain, a lot of times it'll tell you it's a sprain. It gives you clues of what's going on over there. Other things, muscle. You're feeling that there's any hypertonicity. And this hypertonicity, ask yourself, why is it happening? When the muscle is hypertonic, it's usually for three reasons. Either it's guarding for pain, number two is substituting for a weak, deep muscle, or usually, third one I always forget, the pain, weak muscle, the third one.
Hypomobility?
Oh, no, yeah, and then that's right. The third one is there's an instability, and the muscle is just guarding to protect. Okay? So, we're trying to look for that. Okay? And then once you do that, you start palpating, pelvic crest heights, PS IS heights, AS IS heights, the femoral head. Palpating the sacrum, is it twisted? And if it's twisted like this, is rotated here in the right over here, does it follow what the pelvis is doing? So if you're rotated like this, right, that's usually when the left side of the pelvis rotates anteriorly, it will come with the right. We call that physiological sacrum, physiological rotated sacrum. If it's the opposite, right, where this is supposed to be rotated and this is anterior, rotated toward this side here, is unphysiological. Now, unphysiological tells you that it's an SI problem. If it's the other way around, it tells you more it's an IS problem. Right? So that's the basic palpation. Next thing we do is do range of motion. So I'll have you stand over here. And we're seeing what causes his pain. So I have him bend forward over here. Any pain? Right? And then what you do is you push forward here to see if that causes any dura pain. So, okay, that's fine. Dura is gone, right? It's not an issue. Now, what's the pathomechanical diagnosis? So, if it's a flexion problem, I'm trying to see a segment that flexes too much, right? I'll palpate. I say, whoa, this segment seems to be flexed a lot. Is it stuck that way, or is it compensating for adjacent hypermobility? So, if I feel the space over here, I feel like, wow, there's a big space over here. I have him bend backwards. Can he come out of this open position? If he can't, that means he's stuck forward, that means he has some type of FRS. However, if you bend backwards, motion feels good, that means the segment above and below is probably not flexing, and the segment that's in pain flow is compensating. So he's probably, so I test for flexion above the segments, below the segments. Okay, that would tell you whether it's FRS or ERS, or if there's some type of compensation. So that gives you a lot of clues, because if it's a FRS, ERS, it tells you the pathomechanical diagnosis is a hypermobility problem, right? Some type of fixation. If there is no FRS or ERS and it's moving too much to compensate for adjacent hypermobility, that tells you the pathomechanical diagnosis is a hypermobility. Okay, so the two pathomechanical diagnosis is moving too much or too little, and the way you ascertain that is pretty much saying if the person has FRS or ERS, or they compensated. Okay, and if they are compensating, then usually it has muscle guarding as well. So that gives you a lot of clues on the pathomechanical diagnosis, right? But what's going on, right? Oh, that's right. Before I mention, go on further. If you suspect an instability, we need to make sure that the deep muscles are doing their job. So I have the person, I'll test transverse abdominis first. Have the person pull in the stomach, then bend forward, and then improves the pain. That tells me that transverse abdominis is the weak muscle that helps that instability. Maybe it's a multifidus. So what I do is I just resist shoulder flexion and I palpate the contralateral multifidus. And I palpate all the segments. Switch. Palpate all the segments. That tells me which multifidus is not firing. That's a good way of testing the deep multifidus muscles, but you also want to test the global stability muscles. So if the person has pain bending forward, okay, we want to see is, can he control posterior pelvic tilting? Alright, so when you flex your hip, okay, flex your hip, right, like this, okay, you want to see, can he flex the hip without posterior pelvic tilting? Okay, relax. Can he extend his arms, right, without falling into a flexion, right? Right, we're trying to see, does he give into flexion? So essentially we have to do some type of dissociation testing. And your dissociation test that you choose kind of depends based on what's causing the person pain. If the person has pain with bending forward, the dissociation test you use is like deadlift, right? So you tell the person to bend the knees just a little bit and bend at the hips. Alright? Can they bend the hips without flexing here? If they flex over here, that means they have a UCM, an uncontrolled motion into flexion. Relax. Okay? So then, other tests, right? Let's suppose his pain was with walking, right? So I'll be interested in taking a step forward with the left leg. Does he go into posterior pelvic tilt? And he does that. Okay? Or maybe he has pain doing activity, he has to flex his hip a lot. So go ahead, flex your hip, and then I'll pick that functional test. Okay? So your functional global test will be depending on what the patient's symptoms are. So we do all that if you suspected instability, right? So just to kind of recap, we do the pathoanatomical based on our palpation tenderness, gives us the clues and the patient history. Pathomechanical, we do that by testing FRS, ERS. And if it's the instability, we test the muscles, deep muscles and superficial muscles. Now the next thing is what's causing the whole thing. We do something called a driver test. Okay? So maybe something's out of whack and it's causing this to come out of place and compensate. So what you do is you do a posterior glide to the femoral heads, and have the patient bend forward, and you ask them, hey, does that feel better? Yes or no? Okay? And then you go to the sacrum and you nutate it and stabilize the contralateral outside and bend forward. Does it feel better? Yes or no? Okay? And do the same thing to the other sacrum. Right? Then you go to the PSI system, push immediately, bend forward. Does giving stability to SI joint help? Yes or no? Okay? Well, suppose I feel like one pelvis is anterior rotated and one is posterior rotated. I try to de-rotate it. Can you turn around, please? So if I feel this side is higher, I'm going to push this PSI down, and then I'm going to push the other one up and have the person bend forward, and does that improve your pain? Okay? And the last one is the thoracic one. This is the more trickier one. No, the ribs attached to the thoracic spine, so some people think of them as long transverse process. So you go to each rib, you move side to side. That tells you the mobility. exercising the mobility. And then, like for example, Joey has a hard time moving to the right over here. So what I do, I push him to the right and I hold him there. We call it stacking. You push him to the right and you stack it, and then have the person bend forward. And come on back. Okay? So we're seeing which one helps the most. Okay? A little bit more advanced technique. Sometimes patients usually have like 2 to 3 drivers. You fix one driver and you see what happens to the other driver you found to be positive. So for example, if his femoral heads keep popping up, I want to see why is femoral head popping up and though his pain is lower back. Well, suppose I would just stack him here and then have him bend forward. Does the femoral head pop out as much? Or if I give a posterior glide to the sacrum and rotate it, does that help with the popping out of the femoral head? And you can do the same thing, go all the way around. Suppose I give a posterior glide to the femoral head, does that help the continuation? That tells us the drivers, right? And from there, from standing up, you can tell a lot about the pathoanatomical diagnosis, pathomechanical diagnosis, and the driver. And what we do later in sitting changes differently. So in the next videos, we'll talk about how to do the sitting assessment, supine assessment, and the prone assessment. But the last thing I do before I forget is that if any person has any type of tingling, you always have to do a neuro screen. The biggest thing you have to do in standing is your S1 test. Okay? And can the person, Jay, this is side view, please. Side step to right. Pick up your right leg up in the air, and then hold it there, and keep going tippy toes 25 times. Alright, so some people say 20, some people say 25. Make sure people don't cheat. Right? Do a knee extension thrust. So bend, and then some people, they do a little cheating here to get the motion. Okay? So you compare to the other side, normal is 25. Relax, okay? Remember, when you resist plantar flexion with maximum force, that's only 2 plus out of 5. So you might miss a total huge weakness. Okay? Alright, we'll learn more in the next videos.